Okay, so Steve, it's just past, it's 11 minutes past. So if we make a start, that would be great. So I think we're going to hand over to you for a bit of a summary of where we are with community.
Thanks, Katrina. Welcome back, everyone. So the aims for this session, obviously we covered inpatient care, we covered CYP, and we covered the sort of opportunities that exist within the data and the modelling tool as a reference point that's becoming increasingly rich as we load more and more data into it. The discussion about community is fascinating, of course, because obviously we're in the middle of a national strategy around enhancing and optimising community-based care, and it would be great to hear about your local plans within that. I think as we've worked with the region, though, over the course of the last year or 18 months or so, it's been really interesting for us as a team to sort of try and sort of understand the regional story and the sort of rhythm and the way that the region's systems works. And I think we've come around to a view that the community aspect of that is absolutely central. And you know, we'll try and pick this up through the story, but the absolute headlines are that the region's extremely tight and efficient bed base is enabled by having excellent community services. And this is something that we've seen come through in your data for some years, actually. And you know, so the purpose of the next half an hour or so is really to try and understand in a bit more detail how those services have been impacted by COVID, and really, you know, what the next steps are in terms of where we might see that recovery journey go, and also the sort of investment opportunities that are offered by the national strategy, you know, how they're optimised going forward. So it's the same type of structure in the presentation in terms of how we'll organise the charts. So this first one, the top blue chart, that's the UK-wide experience of referrals to CMHT care over the 16 months of the pandemic, going back to April 2020. And you can just visualise there. So normally per 100,000 population, a system would generate about 400 referrals to adult and older adult CMHT care. So you can see that in April, we had this very drastic position where referrals were only just about half the expected rate. We saw that recovery take place, sort of peaking in the summer around July, and then that hesitancy through the autumn, the next national lockdown coming to fruition. And really, sort of only the light at the end of the tunnel in terms of recognisable historic levels of demand only starting to appear in March 2021. So if you take the overall cumulative impact of that April position through to the end of March 2021, it actually means that there were 12% fewer referrals made to UK community mental health services over the course of the pandemic. So in terms of the size of the hit, we had 12% fewer people coming through the pathway. I mean, it sounds quite drastic, doesn't it? And actually the story for CYP was quite similar. I think it was about 11% fewer young people came through the pathway. But if we compare this with all other aspects of healthcare in the UK that were impacted by COVID, you know, so we're all seeing the sort of 5 million plus waiting list for elective care, which are being dealt with by physical healthcare providers at the moment. You know, the UK Mental Health Service did incredibly well, really, to keep the show on the road during the pandemic. I think that's our core position through this. And then as we've got to sort of reopening of the society from March onwards, you'll see that from the data there that referrals have really now started to steady at a rate which is at least the old levels. And actually in some months, we're above those levels now. So the bottom chart is the data for July 2021. Remember, this is UK average data. So across the UK, it was 414 people per 100,000 adult and older adult population being referred. So that's now 2% above the pre-pandemic levels. And across the southeast, it was 373. So that's about 10% below the UK average. But southeast, remember, 10% below the UK average is not 30% below the UK average, which is where we are with beds. I think we have to remember that the southeast's overall needs position on the NHS England's PRAM needs adjusted methodology in terms of CCG baselines is somewhere between 15 and 20% below the England average. And that is articulated in terms of lower bed numbers. But actually, one of the big enablers of that is that referrals to community-based care are really at a higher level than we would expect to see because of the region's needs index. And that's really emphasising that the region has pretty much always had a community-first ethos running through its provider sector. And you can see if you look at the data here, we're not seeing that concentration of providers in the bottom quartile here for CMHT referrals that we saw on the bed numbers, but the region's providers generally are positioned just below the overall NHS average. We've got one provider there which bucks the trend, which is Kent and Medway, actually, which is fascinating for us. And I think it starts to tell a story about concentrated demand within that patch. And you know, there are areas within Kent and Medway, the Medway towns are the obvious ones, and that sort of border area with London where there have been high levels of demand consistently in recent years. But we take that overall regional position, it is fascinating, but look at Oxford Health there, just below the UK national average. We've got, you know, so a very different position than where they occupy with beds. Same's true for Southern. Same's true for Sussex Partnership. So generally most providers move to the left compared to where they are on their bed base. So we've got more community care being the sort of general ethos within the South East system. So that's referral levels. And remember, this is now the region's longitudinal stories as a group of 8 providers. And it pretty much maps that national pathway, doesn't it, in terms of demand falling very strikingly during April, recovery taking place, actually breaching the historic levels during July, which was fantastic. Very, very close to the historic levels actually through the autumn, some of the edge being taken off that with the next national lockdown. But actually what we might read into this data is that the region has pulled out the stops to keep that CMHT pathway pretty much open during the course of the pandemic, which is great. And really from March onwards, you're seeing demand now being above what we might expect to see in terms of those steady state norms. So remember, we talked about a 12% reduction on the UK national pathway in the COVID year. Well, what did the South East do? The South East actually had a 5% reduction. So that's the cumulative impact of all that monthly data. So we can pretty much confidently say that the South East managed to more successfully keep open that community mental health team referral pathway to, you know, to a greater extent than we saw across the rest of the UK. But interestingly, the region is now bobbing away at a level which is above those historic demand rates. So it starts to raise questions about what the future CMHT care offer is for the region. This is just a reflection now. We'll look at caseloads for the region in a second, but this is the history of national caseloads. And this is quite a complex and nuanced story. So remember the bed story that we saw? We looked at this as well, didn't we, in terms of length of stay and also bed occupancy. So the blue areas here, this is 9 years worth of data in the pre-COVID position. And there's a fascinating story here, but it's actually a story of marginal decline in CMHT caseloads. In terms of rationalising this, there's probably really 2 important dimensions. One is the rise of IAPTs, and we might have seen that people with common mental health conditions, so severe anxiety and depression, may well have been on CMHT caseloads back in 2013, 2014. But as IAPT started to motor, and we went from 300,000 people on using IAPT through to 1.1 million in the pre-COVID year, we can legitimately expect to see that people in those non-psychosis clusters might have started to be directed towards the IAPT pathway more than the CMHT pathway. There have clearly been some areas of growth as well in CMHT care. So we know that perinatal perhaps led the way in terms of, you know, an increase from 10,000 people on perinatal caseloads across England about 5 years ago to you know, close to 50,000 now. And we also saw EIP, of course, being another leading edge part of that pathway, which has seen you know, fantastic growth in recent years. So where did we get to in the position just before COVID? 1,632 people per 100,000 population. Remember, that's adults and older adults. And then we started to see that drop during COVID. And that drop really peaked in April. So it was 1,460. So we had about 10,000, sorry, we had about 10% fewer people on CMHT caseloads actually in April. So there was a mass discharge programme that took place, perhaps unconsciously, but it took place across all UK providers. What did that mean for England? Well, it probably meant that there were about 70,000 fewer people on CMHT caseloads in April and May 2020 than we were used to. The good news is that we have seen elements of recovery through the summer, through the autumn, and through the winter. In terms of where we are now, we're very, very close actually to where we were in that sort of pre-pandemic position in terms of caseloads. We'll look at the regional story now and the spread across the region. So top chart again was the pre-pandemic position. I think what has fascinated us here, you look at the overall macro metrics for the region. So the national average 1,632 people per 100,000 pre-COVID. Southeast region as a whole was 1,341, but that's 18% below the regional average. Remember where we are though with acute beds, 30% below the national average, and that's even where we are today. So the region is much closer to the national average in terms of its CMHT caseload. So again, it's that ethos of community first wherever possible, which is evident through the region. But look at the range between providers. This is now territory where we start to see differences in service models, much more than we do within inpatient care. Remember that very strong clustering for acute beds we had in the bottom quartile, with just Sussex and the Isle of Wight edging towards the NHS average. That's now not something that we see within CMHT core offers, where we see a real spread across the region. So the two providers that pre-COVID had high numbers of people on community caseloads were very much Solent. We have a fascinating service model actually around industrialised offer in terms of CMHT care. Berkshire also above average, Sussex and Kent close to the average. Surrey interesting, so low beds and low communities. So there were just issues about capacity and scale within the Sussex service, and also Southern within the bottom quartile. But the bottom chart now shows us where we are during July, and we've seen a little bit of a shuffling of the pack taking place. But interesting for us, Solent are still leading the way with that industrialised care offer, very much in that top decile actually. Actually, sorry, there are probably some animations on these charts here. We're also seeing Kent and Medway, remember high referrals in Kent, and also Sussex being above the national average, Berkshire close to that national average, and then we've got Isle of Wight towards the top of that bottom quartile. So it really just leaves Oxford, Surrey, who are both systems with very low levels of baseline investment in mental health service, and also Southern in the bottom quartile there. And you can see where the region appears as a whole, and caseloads in July were just 2% below where they were pre-COVID. So we have now seen pretty much a full recovery in terms of CMHT caseloads like we have for inpatient care as well. That's now the story in terms of the number of contacts delivered. This is a positive story. So look at the top chart there. So the national average pre-COVID was 30,000 contacts per 100,000. The regional average was 26,000 contacts. So let's look at those headline metrics now. So 30% fewer beds, 18% fewer people on caseloads, but 12% fewer CMHT contacts offered. So we've got a story of more intensive care being offered for people who are on regional caseloads. And you can see that most of the providers within the region were starting to gravitate towards the centre of that distribution there, with of course Solent, it's still being positioned very much within that the top quartile end there. We've got the position for July in the bottom chart, in the bottom area of that chart there. And again, the region's maintained its position there. So we've got about 25,000 contacts being delivered on an annualised basis for the region. So very close now to that pre-pandemic position. So the recovery is very evident, I think, is the top line story for the region's providers there. And you can see that Solent, now Southern, and also Kent, total contacts delivered are above average. For Berkshire and for Sussex, also close to the average, and just Oxford, Surrey, struggling to some extent because of that sort of baseline funding issue for those systems. So contact rates have recovered, referral rates to some extent have recovered. These are those contact rates, taking that longitudinal view over that 16-month period there, and you can see the recovery effort now very, very close to historic levels of care. And if you take the last 5 months, actually, with that sort of high level of care being delivered in March, we've probably got an absolute level of community-based contacts, which is very, very consistent with the pre-COVID position. So we've got a recovery position, which is evident for the region. So what type of care is being offered? We'll look at the face-to-face versus digital offer now. The national one there is about face-to-face care on the top chart there. So the first bar there was at 76% of all care was delivered face-to-face pre-COVID. Then the position for April, we had that cliff edge and we fell to 29% across the UK of care being delivered face-to-face. We now more than half of care is face-to-face in all CMHTs, which is great. So 51% position across the region. We've just got across the UK. And we've just got the non-face-to-face position there on that bottom chart. So in terms of the non-face-to-face care rankings, actually Berkshire, 70% have still got the most non-face-to-face care. But you see that Kent and Medway are now appearing in the bottom quarter. So this leads us into the digital discussion in a second, actually, about how much of that non-face-to-face care is digital and how much of that is telephone-based care. So that's the region's story around non-face-to-face care. And you can see that from April, we have got an overall trajectory of lower levels of non-face-to-face care being offered there. And it has been declining over time as face-to-face care has recovered. And in July, it was 54% of all care was non-face-to-face for that group of Southeast providers. So this is the digital part of the story. The top chart is UK data, UK-wide data, and there has been what we feel is a practice issue in adult and older adult CMHT services. So remember the great success story we had in CAMS and across the region. Remember, we breached 30% in some months for the amount of care that was being delivered through digital platforms, CYP services. However, across the UK, adult and older adult CMHTs have really struggled actually to mobilise that digital effort. So first month there, 3% of care in April 2020 was delivered through digital platforms. We did see a gradual increase, but remember that peaked in about January at 7%, and it's been declining since, really, back to about 6%. So for whatever reason, whether it's digital deprivation, whether it's a practice resistance, we have not been able to industrialise that digital care offer in adult CMHT services. So there is a discussion point for everyone there about what next. And what we're doing really in a lot of the seminars that we're holding nationally is that we are highlighting the Southeast region as the best practice region for digital care. So if you look at the region's data, even in July, it was 10%, so pretty much double the national coverage on digital. And look at where some of the region's providers were. So best in the UK was Surrey, second best were Oxford at 15%, drawing with Berkshire also at 15%, and then we've got Sussex coming through there at about 13%. Southern also well above average there. So it's a really fantastic good news for the story for the region there about reinforcing the digital care offer within the adult CMHT pathway, which has not been achieved elsewhere. And that's the story of the region's offer there within that digital offer. So we had low baseline, accelerated delivery, some element of decline, evident though as we've gone back to elements of face-to-face care. So as Katrina made that point earlier, it's fascinating to us that we are seeing some return to face-to-face care and some reduction in telephone-based care, but it's only marginal. And in some ways, it seems to be that face-to-face care is substituting for digital rather than that telephone based offer. So there is a discussion point there for everyone. We'll look at the crisis pathway now, because this is important both nationally and regionally. And again, that crisis pathway was impacted by COVID, which you can see in that top chart there. So remember, this is UK-wide data. Of all the bits of adult mental health services, though, and we will all understand and empathise with this, it was the crisis pathway that came back first in terms of recovery. And actually, in terms of absolute recovery, that was achieved in March 2021. And since March, we've had pretty much every month achieving the same level of referrals that we would expect pre-COVID. Slightly interesting, though, position for July, where we had a dip in referrals, and we'll be keeping an eye on that one. But it is a fantastic recovery overall from where we were in April, where CRHT referrals were 29% lower than we saw the pre-COVID days. So that must have had an impact on service quality across the NHS. In terms of the South East story, the South East average is very much in line now with the national story. And we've got some of the providers actually having much higher levels of referrals than national averages at the moment. So Berkshire and Sussex are well into that top quartile nationally, and also Oxford and Kent, much higher CRHT referrals than we see compared to the national average. The region story on its own, CRHT recovery, very much maps the national average, so real impact in the first month of COVID. But remember that national data, if we take the take the referrals cumulatively, 29% fewer referrals in April, and the South East story, we had that recovery where actually referrals were 14% above the steady state position for the region pre-COVID. Remember that the gap we were seeing for the national story, though, which was 12% below in July. And what we're doing really on that regional story is we're articulating what's playing out in Berkshire, Sussex, Oxford and Kent. So the region overall at the moment, you know, there's something going off maybe in the crisis pathway where things are starting to overheat perhaps. But we think this links quite closely with the region's low reliance on acute beds. So if there are elements of enhanced demand coming through, they will be articulated first within the region in that crisis pathway, because of the, you know, we have a very sophisticated and open access crisis pathway which plays out within the region. So let's look at the regional contacts within the crisis pathway. So again, the top chart there is a pre-COVID position. So nationally, it was just under 6,000 contacts per 100,000 population. The region was about 5,500 contacts. So just about 10% below the national average in terms of contacts. And that compares, remember, you know, this is a system which is operating with 30% fewer beds. So the crisis pathway is helping to make that link, you know, in terms of making that 30% bed base sustainable, really. And we've got the story there for July. And again, the regional average is really quite close to the national story there in July 2021. And you can see that recovery there, which is evident within the CRHT contacts. Remember that this isn't referrals now, it's actual contacts delivered, where the region's recovery is pretty much intact there in July 2021. So Katrina, I'm probably going to hand over to to group members now, if any of that was valuable. I think for us as a team, what we've taken from the data was that the community offer is really key in helping the region to live within a very, very tight bed base. There's far more activity goes through the crisis pathway, though, in the region than we would expect to see, because it's really that link between the CMHT offer and that very, very low bed base that the region is delivering. The region overall managed to keep the doors open during the COVID year with far higher levels of activity than we would expect to see. And we also saw a greater commitment to digital care in the region, pretty much double the national rates that were achieved elsewhere in the NHS. So there are some good practice points, but of course, I suppose a lot of the interesting aspects of the discussion might be what happens next and where the data takes us next. So I'm not sure if there's any immediate questions coming through in the chat, but I'll hand over to you now, perhaps, for any areas of discussion.
Brilliant, thank you very much, Steve. And I think what was so helpful about that discussion is it's connecting, it's that kind of narrative around connecting things together, rather than just looking in isolation at different bits of our kind of service offer for mental health. So really helpful, that connectivity. What we plan to do in this session is actually just have quite an open discussion. We know there's quite a few of you. We had some late people coming to the meeting, so we aren't doing breakout rooms, but we're hoping that either through the chat or through people putting their hands up, just to have a bit of a discussion. I mean, certainly the areas that you've highlighted and talked about in relation to the data is obviously around referrals, caseloads, contacts, mode of delivery, and also the crisis pathway, Steve. But your question you just raised is the kind of the what next, and I guess that might be an interesting place to start. But Michelle, I think you're going to keep an eye on chat, if that's all right, and just see what's coming through. So again, hands up, comments, thoughts, reflections. Does this kind of echo some of what you're seeing within your systems? Do you have a sense about the journey moving forward? Sam, interested from your perspective in relation to the work you're doing in community transformation, whether there's any reflections from your perspective as well.
It's gone quiet. Just to help frame the thoughts, so some of the possible questions we'd put forward or kind of prepared in advance was, in terms of what had been demonstrated, does that data look like the data that you're seeing locally? So that could just be a simple yes, no at this stage, if we've just bombarded you with a bit too much data and you need a bit of time to digest it. Or
it's a really good point, Michelle. And of course, I talked super generically, apart from the CRHT issue, about all of those community teams, and there may well be issues within certain teams. We know eating disorders, adult eating disorders is emerging as a real area of concern at the moment. And we'd be really intrigued what people's experiences are. Helen, I think you've got your hand up.
Yeah, thanks. I can just respond to the adult eating disorders picture, Steve. So we've certainly seen an increasing demand pressure in the Surrey footprint, which has had a further impact on our acute hospitals, who are trying to look after some of those individuals, as we don't have any, specialist hospital provision within our footprint. Although we have found a sort of temporary solution by working with NHS England for the next few weeks, but it's a real area of concern for us. In fact, eating disorders across all ages really, which is why I put it in the chat as a kind of subject area for deep dive and thinking about what else we can do at an earlier stage, if anything, and is there any sort of learning that we could really benefit from that's out there. I suppose just in terms of the broader slide deck, I thought it was incredibly helpful, Steve, as always. I'm always in admiration when you speak and you make it all make such great sense. But I feel like I need to digest it. But I guess I was thinking about the broader offer again and mapping on top of what you presented to us the other elements of our care pathway. So I was thinking about our crisis services and where other partners, particularly those within the third sector, play in as part of the offer, and our social care partners, and trying to bring that together into a more comprehensive story across our footprint. So that feels, within Surrey we have an improvement plan, and a review of the crisis pathway is part of that. So it feels like this is a really useful starting point for us to build on and map that data against. So yeah, it would be really useful for us to take that away and work on it, I think.
Thanks, Helen. Maybe if I just come back one of those points initially. So the eating disorders is fascinating at the moment across England, and well, we're also doing some work in Wales actually, which it seems to be an area of high acuity. Just for information, I don't think there's ever been a successful sort of prevalence study of eating disorders that's been conducted. It's the new morbidity, isn't it, in many ways in mental health, like CYPMH is the new morbidity in child health. And BEAT, who do fantastic work, actually they estimate 1.25 million people in the UK may suffer from a diagnosable eating disorder. But last year across England, only about 11,000 people were able to access specialist adult eating disorder cares delivered by statutory providers. So it would make eating disorders the psychiatric specialty with the largest gap between prevalence and provision. So about 1% of people in need may be able to access a service. So the gap is extraordinary, actually, and it will be interesting to see how we all cope with this sort of surge in morbidity which is coming through. We just completed a point prevalence study actually for the NHS in Wales, which was looking at community-based demand, and as ever, there was a story of increasing referrals and need being articulated. But we also did a census of everyone who was in a bed, and it was fascinating actually, because about half of people with a diagnosable eating disorder were not in psychiatric beds, whether they be for adults or inpatients. So they were in peds beds, they were in general medical beds. So I think there's something for the NHS as a whole about understanding where we are now in terms of that pathway, and the incidence of use of the use of restrictive practices around feeding as well also give causes for concern there. So I'd regard it as an opportunity where we might be able to through the data, maybe establish some more insight or a more confident baseline. And maybe just one final word, Helen. Really fantastic to hear about the crisis pathway work as well. And I think that's a really good hook into the community transformation work actually, and the NHSE strategy around that.
Thank you.
Mike, I'm just aware your hand's up, but just Steve, I wanted to pick up on what you just said in the context, Helen, of your question. Hugely important, and I think the kind of the narrative and the data that you just shared, hugely important. So with the data that we have across the southeast, in terms of doing that kind of analysis, I'm just wondering about it being a focus of one of the future sessions, or potentially whether it's something we could do earlier, given the kind of the urgency, if you like, of the needs of this cohort of patients. And maybe that's something we could look at. I don't know if that would be helpful for others, but actually having a really good look at the data, and also the national trends and just some of the treatment gap that you're describing would be great. Yeah, thank you, Helen. So maybe we could pick that up and see if we could run a session on ED. Great, thank you. Mike.
Hi, just switching it up and broadening the coverage of the discussions as well. There was quite an interesting discussion going on in the chat around digital and the differences between adult and children's take-up of digital. I think there's something that I'm interested in as well around what digital means, because that's quite an umbrella term as well. And you do have the emergence now of these new sort of like self-guided support tools where practitioners are working with children, but actually a lot of the therapy is taking place with the children themselves using the tools. And that's also happening in adults as well in areas like IAPT. And at the moment, we've not got that split of digital where basically it's a face-to-face conference but using digital technology, but also this emerging trend of particularly younger people using their own tools but guided by a practitioner, but not particularly led by a practitioner. So I think that's one of the things, and acknowledging what Tim's saying in the chat as well. I think it is really interesting because we don't really have the research yet to understand why that disparity exists between adults and children, because we've all got theories about why that's happening, but there's, as far as I'm aware, and I'd love to hear if I'm wrong, there hasn't been any substantive research done on that, particularly over the period of that big transition. So that was just to add in to the conversation.
Thank you, Mike. Really helpful reflections. And I think as much as anything, as always with these sessions, Steve and colleagues, it's that opportunity to really think about what the data is telling us and what it means. And I think that's what you've reflected, Mike, and certainly within the kind of IAP space, really thinking about our offer, and certainly with digital, you know, what's the best practice offer, and is it meeting the needs of our service users within IAPT? The other bit of national guidance, just as context for people, is that informed choice from our service users rather than service availability is something that's been really picked up. So interesting point. Thank you, Mike. Michelle or colleagues, I don't know if there's, oh, Nadia, your hand's up. Sorry.
No problem, thank you. It was just going back to the eating disorders conversation, and Helen will know this, and so will some of the other colleagues on the call. And certainly we've been seeing an increase of what is the RFID, or the disordered eating, and certainly presenting into our acute settings where they kind of get stuck. And I guess I'm wondering whether some of this data does reflect that, or in terms of the RFID prevalence, and I think that's becoming a growing concern. And I expect that that's probably happening for some of our adults as well. So we are certainly seeing a lot more of that, and so it's just how do we reflect that and make sure we've got the data that helps us then to plan and put things into place for them.
Thanks, Nadia. Yeah, there's a consensus here today, isn't it? It's fascinating that, you know, whether this is, I mean, clearly this is all hugely multifactorial, but eating disorders and the anxiety around the pandemic has turbocharged the incidence for providers and commissioners, and we're in the process at the moment of absorbing this and developing plans and strategies. And if we can have that seminar or that time out to consider where we are, I think we would really value that. And we, as well as that Wales deep dive, which covers acute and paediatric environments, I think we're about to do the same work in the Southwest actually. So I think we can bring some valuable context from elsewhere. But there's an absolute consistency around the message now that adult and CYP eating disorders are an issue, perhaps an unanticipated issue, which is increasing at pace.
Thank you, Nadia. Thank you, Steve. Really helpful points. Michelle, I don't know if there's any other
questions. So the questions so there's no other specific points apart from Karen, who's suggested that perhaps we could use this forum to share best practice or different approaches. Okay, I've just seen Sarah's hand up. Sarah Fellows.
Sorry, everyone, I had to step out and just go to another meeting, just come back, and it's just been really, really interesting. And I just wanted to ask Steve a really quick question very briefly, if it's okay, Steve. I think Steve knows him well enough to know that it's likely to be a really stupid question and will no doubt embarrass all of my colleagues horribly. But you know the people that have been discharged during COVID from CMHT caseloads. I'm really sorry, I can't remember the exact figure that you said. If you don't mind me asking, do we know that they are discharges and not deaths? Well, I suppose it's the same thing, isn't it, really? Because if you do die, you will be discharged. I just wondered if that was a factor.
No, it's a good question, Sarah, and it really is a bit left field. We haven't considered this before, and I think you've made a really good point there. I mean, clearly, you know, that COVID is because it didn't.
I know, because I'm so sad. While you were talking, I did a bit of a Google of the numbers of Southeast deaths, and it didn't look to me like it would be massively out of kilter for at least that to have been a factor, if that makes sense, during if that makes sense, conscious of COVID, etc. I just thought I'd put it out there because, like I guess like you, I wouldn't have expected us to be discharging people from CMHT caseloads, do you know what I mean, during that, at an increased rate during that period, if that makes sense. Do you know what I mean? But there could have been very good reasons for that, and I'm sure colleagues from providers will know that. Do you know what I mean?
Yeah, no, it's a very challenging question, Sarah, and it's absolutely right that you've asked it. We will have some data actually. I mean, we're just in the process in the last few weeks of finalising our annual benchmarking reports, which everyone will get, and they will describe that COVID year in a lot of detail. So we are going to focus on the acuity profile of people who experience services. I'm going to do that by using the cluster analysis. So we'll be really intrigued actually about the share of caseload that are allocated to specific clusters. So did things happen maybe around the PD cohort? I think inevitably there might have been something that happened around the older adult cohort. So if we end up looking at clusters 18 to 21, and were they disproportionately affected by that reduction in caseload that we saw? So I'm really excited actually that because we've got these events quarterly or even more frequently if we need them, that we have that opportunity to come together to play in this really interesting data that we're gathering and researching all the time. So eating disorders we talked about today, we talked about the curiosity really and that intrigue around what happened to caseloads and people's access to care. There will be other themes as well. Katrina, maybe if I could just mention one other thing that we're doing, and everyone's welcome to attend this, and maybe Ellie or someone could put this in the chat, but on the 29th of September, we're holding a BAME Equality Seminar, and it's a UK-wide event, this, and Katrina and I have had a very brief chat about this, and we're trying to get some baseline data for the region at the moment. And we did a deep dive for London actually, and unfortunately wherever you look in mental health services, you will find equalities issues for BAME people. So at their most acute, there will be, say in secure care, forensic care, you will have a massive overrepresentation of Black British people in low and medium secure beds. But unfortunately, even within CYP services, at the moment UK-wide, we're seeing an underrepresentation of BAME kids in services. So we would really encourage anyone that can make it to attend this event, and we'll be trying to mobilise some of this data. We've also got Lade Smith and Rajesh Mohan, who are the two presidential appointees for the Royal College of Psychiatrists, who are going to talk about their experiences actually in terms of what they define as institutional issues for mental health care for BAME people. So I think there are so many fronts we can have interesting conversations actually, and maybe Katrina, that might be another thing we can bring to a future meeting.
Absolutely. Steve, that's incredibly helpful. And thank you, Ellie, for posting that in the chat, but we'll also send that round. Oh, Helen, you've just said it. We'll send it round with the recording, although I think it takes a few days, Michelle, doesn't it, to get the recording uploaded, and certainly the slides as well. But I think we're also transcribing this, which is really helpful. And again, if we are able to do a more in-depth session, I think that would be fantastic. And I think, Ellie, you've just referenced another couple of events. I've signed up to all three of them because they all look really good. So I think there's also CYP equalities as well, isn't there, Steve?
Yeah, yes, we have an adults benchmarking conference this year on the 8th of October. We've got a CYP conference on the 2nd of November, but both of them have national speakers actually. So Pratibha Chitsabasan as NCD will speak at the CYP. I think one of Claire's team will speak at the adult one. It might be Phoebe, I'm not sure, but that there will be a national policy presentation there. But I think we just want to make sure that colleagues in the southeast, have an opportunity to take part in those. Yeah.
Brilliant. No, absolutely. So we'll make sure that they go round with the all the other information from today. Just wanted to pick up Karen Stevens. You've put a couple of really helpful points in the chat about using the data to identify best or different practices, and also something about how we share, and again using the data to really inform discussions around how we're delivering care and all the kind of sharing around that. I mean, Karen, I don't know if you wanted to say anything else or whether you wanted to put something else in the chat, but again, we're very happy to facilitate what's helpful out of these meetings. So any other suggestions about what that might look like? I mean, it might be the more in-depth theme discussions, whether it's on BAME or eating disorders, and then actually that could form part of it. Might pick up your point, Karen. Okay.
Sorry, I can't really talk. I've got some drilling going on in the background, so I kept myself on mute.
That's
I'll
fine.
respond in the chat.
Brilliant. Thank you, Karen. Thank you. Bikram, I think we've got a hand up from you.
Hi, thanks. Yeah. Just want to go back to one of the earlier points in the first half of the presentation that Poppy made about the data sources. Just about that, if possible, we know that we are using more voluntary sector services to deliver a lot of the work. If we could get that data, and if that is available through this SDCS or whatever, I would really encourage that. It would give a wider or more accurate representation of what's happening across the system. I know certainly in primary care as a GP, I am quite often referring people with low-level stuff to voluntary sector rather than to any other statutory service, just because the waiting lists are so horrendous. So, you know, things like that then becomes a hidden waiting list, doesn't it?
Thanks, Bikram. We really, you know, it's a point that's been made earlier. We do agree with you. Mike and I had a quick chat in the break about tactics for us accessing the data. So let's see what we can do in terms of mobilising the sort of whole quantum, and we'll bring it back. And but yes, a point very, very well made, and we'll do our best for the next seminar to include that.
Steve, can I just following up on that as well, Steve? Yeah, I'll have a look around in the SDCS. In the Northwest, I'm not very aware of other regions. I've come from a provider in the Northwest. In the Northwest, one of the issues we do face is that voluntary providers don't have the kind of ICT infrastructure to upload SDS data as well. So I'll absolutely do the work to look at that, but we should just be minded that that might still only be a partial view of what's actually happening. But I'll feed that back into the next meeting.
Brilliant. Thank you, Mike and colleagues. And just to say, there's a couple of really helpful additional points, I think, Michael Scammell, in relation to new primary care-based interventions, and also from Nadia in relation to perinatal. So, I mean, I think it's such a great opportunity, isn't it, to have conversations and discussions that are based on the analysis of the data which you've outlined, really. So very helpful. And I think very much, Sam, aligning with the work you're doing in community and thinking about how we work together around community transformation. So as always, huge thank you to you, Steve, and the team for the fantastic work. As you said, Helen, I always learn so much from these presentations, and it's just so great to hear the richness of the intelligence in relation to the data. We've agreed some actions, so we will pick up on those, and Michelle work with NHS benchmarking colleagues in relation to sending around all the information, the events, but also looking at an additional session on ED, and then potentially looking at whether we can do something on BAME as well. So very big thank you to NHS benchmarking colleagues and everybody that's joined the meeting today. And yeah, we'll be in touch and look forward to seeing you at the next session. Thank you.
Thank you, everyone.
Thank you.
Thank you. Thank you all.